Pushkar Shikarkhane, and I welcome you all for the today's focused session on POCUS. That is your point of care ultrasound, and it's a very special device that we are going to introduce you to all today. That is a handheld ultrasound. So I am a consulting physician, MD medicine, DSP medicine. I am attached to Lilavati and some more hospitals. My areas of interest are sleep medicine and metabolic diseases. I am also interested in obstetric medicine, where I deal with pregnancy-related medical problems. So I am in consulting practice for almost 30 years now, and as an MD medicine, probably I never imagined that I will ever speak on a topic of ultrasound, because obviously that's not my area of interest. So when I first got a call from our admin team of Lilavati and later from Dr. Ajit, I was thoroughly surprised at how I was chosen as a speaker for this particular event. But later, as the concept got clearer to me and the availability of the device, which is from the GE company, which is we are going to see today, the technology has now allowed me to talk on this topic. See how the time changes in a very short span also. That's something which I never imagined will be my topic of deliberation ever, has become actually a reality today. So, moving ahead, we are going to talk of POCUS, that is point of care ultrasound, the visual stethoscope. So I am a doctor, being a MD medicine consultant, we always have a stethoscope around my neck, without which I will not enter the hospital. But today I especially kept the stethoscope away in my car only, and I come without the stethoscope. Because if I am believing something, I should behave in the same way. समझो बारिश की गॉड की पूजा करने जा रहे हैं, somewhere if there is a सूखा चल रहा है, if you are not having बरसात नहीं हो रही है, and if there is some, there was a puja held for that. This is a story which you might have read also earlier somewhere. Many people went for that puja, but only one man went with an umbrella, because he believed that this puja is going to be effective. So if I have to come here, I have to come without a stethoscope. So I came in the same way. Because this is going to be, or this already has become, an adjunct to emergency and bedside diagnotherapeutics. Though it is not become that common, obviously the price bar is a significant factor there. But as we have all seen, any new instrument when it gets introduced in the market, it's already having a very high price tag. But later on, the prices do come down. So at present, when I checked with the company people, this device which they are introducing is costing 10 lakh rupees. But they are hoping that one day or the other this will be manufactured in India and the prices will come down. And as I told them that every doctor should actually walk in with this kind of a stethoscope only in the hospital as they come in, which will give us so much extra information. We are, the topic today I will cover will be in this manner. We will first see how the physical signs that we were all talked about, or we were taught about, have now been getting shifted to a targeted visual trial with the help of technology. We'll discuss some cases, one on trauma, shock, and dyspnea, and then we'll see what are the pitfalls in this technology also. So we are talking about ultrasonography. You know that ultrasonography works on the physical phenomena of reflection, that's the echo. So what waves are used in this? So these are ultrasonic waves which are more than 20 kilohertz frequency, and they are inaudible to the human ear. What the device does is that it judges the nature and the depth of the tissues depending on the quality of reflected waves and the time at which the waves are received. So it all depends on the body on which the probe is held, and from there we send the waves inside the body. The waves hit a particular organ, and then the waves are reflected depending on the reflectivity of that organ or that particular medium that through which it is passing, to make the contact very good, because air is the bad transmitter of the wave. Air will reflect it immediately. So to make contact has to be with the jelly. So air and bones reflect the waves, and fluids allow the waves to pass through easily. And solid organs also allow the waves to pass easily, and partly they get reflected depending on the actual structure of the organ. The advantage of ultrasound that it is easy to use and it is becoming easier day by day. That's what we are here today for. That how easier it has become to use ultrasound in our day-to-day clinical practice. And definitely there is no radiation. That's a big advantage. But at the same time, it is observer dependent. So we need to learn it. It's not very easy that you just do it and you get. Even that also the technology is making it easier with the help of AI. As I was discussing with a company person, probably we will be just holding the probe on the skin at the particular spot that they want us to hold, and machine will do almost everything else. The machine will calculate and will give the information by using AI. So that's the wonder of the technology that we are all going to experience. So let's see how we are now moving from the physical science to the targeted visual triage. The transition of point of care ultrasound from a specialized radiological tool to a visual stethoscope is definitely a profound shift in the modern medicine. This is how the technology is evolving by leaps and bounds. And it has shrunk its size from the bulky card to a highly portable handheld device. Like to an extent that I was chatting with a company person and I asked him that how do you secure this machine? Because it's costing 10 lakh rupees and it is so small portable, it can be easily misplaced somewhere, it can be easily carried by somebody somewhere outside. So there are ways and means. I think during the old days program, those ways and means also will be told to you. There will be some tracking of the device which can be done, and there will be some log which can be maintained, because it can be misused also, especially with the restrictions which are there by the law that we are not allowed to disclose the sex of the baby. It cannot be, ultrasound cannot be done outside a particular setup to maintain that kind of a restriction. So that where this machine can be misused also. That's why definitely there are going to be some restrictions on that. Obviously, you know that the traditional stethoscope has its acoustic limits. When we are in a chaotic environment of an emergency room or intensive care unit where there are so many people are speaking, there are noises of the alarm which are going on, and at the same time you put on the stethoscope and try to listen to RAS and try to look for bronchial breath sounds, and you see whether absent breath sounds and all that. It is really difficult. So that can be definitely changed, or that problem can be circumvented by using this particular handheld ultrasound. And obviously with people with thick chest wall and the pathologies when they are very subtle, they can be easily missed with the usual stethoscope. So this particular technology is definitely a big leap in helping us to diagnose the disease better and faster. Though it doesn't replace the physical examination, so we cannot go away with the feeling that now there is no need to do any physical exam, no need to do palpation, percussion. Obviously, that is going to be there. The observation, that is our initial inspection, obviously also matters a lot. But this technology will definitely supercharge our blind acoustic guesses into an immediate visual answer. So that is the beauty of this particular technology that we are going to use. So let's see the first case in a emergency setting, how this technology can be used. Let us see how it can be used to an advantage. So case which has come, a 34-year-old male with a motor vehicle collision, road traffic accident. He has presented with a GCS of 13, but the BP is low, heart rate is fast. So there is hypotension, tachycardia. On physical exam, he has muffled heart sounds and abdomen is soft but is distended. So at this stage, in a routine way, what we would have done? Anybody? If we did not have the technology, what we would definitely do for this is some kind of a imaging. But this imaging means you have to call up the ultrasonologist. The sonologist may not be there in the premises at that moment, and then you get held up. Then you feel, oh, the sonology is actually more difficult to do. It is better to deal in this patient for a CT scan. But you want to take the patient to CT scan and find that there are already 2-3 patients are queued up there, and then you have to push this patient ahead and get a CT scan done. So the time is money. Here the patient is already in hypotension, the tachycardia, and we can't delay like this. So that's how these kind of technologies have been used to the advantage, because when the backup from the radiology side becomes sometimes difficult, so they wish to give us the services at the earliest, but they cannot at times. Then we have to become self-independent. So this is how we are not having. I can see our radiology friend is smiling at what I'm talking, but we are not going to take away what you are doing, but we are just trying to be self-reliant so that we can reach up to some level our own on our own, and maybe leave it the remaining for you to do the more classic work where your expertise will be really used. So that is where we are. Uh, the EPAS section, the EPAS protocol, that is extended ultrasound, the PROA protocol, which will be used, and which you will put the probe on the right upper quadrant, left upper quadrant, subxiphoid, and also in the pelvic region. And in that you find that there is anechoic fluid strip in the Morrison's pouch, and also in the pelvic view. So I can see some residents are sitting here, so if you want to put your guess. What is Morrison's pouch? Where is it located? Can anybody just quickly shoot NEET exam question? Where is Morrison's pouch is called as dash recess. Splenorenal, hepatorenal, vesico-ureter. ऐसे चार ऑप्शन होते हैं, unless they are given four options they will not answer, because they are so used to having multiple. जगह एक पे टिक मारना है, तो उसके चार ऑप्शन देने पड़ते हैं. So it is a hepatorenal recess which is there, and we are seeing anechoic black fluid strip there, and also in the pelvic view. So what does that mean? What does this mean? It is that there is fluid in the abdomen in an acute accident setting. So in all possibility, this is hemoperitoneum. So you will not wait for even CT scan to be done in this case. This patient will be straight away wheeled into OR, the operating room, and will be taken up for surgery. Now this was possible because the EPAS protocol was used here, and EPAS protocol would be implemented because we had a easily accessible handheld ultrasound. It may not be handheld always. Right now, I think we have the bigger machine which are there in our ER. Dr. Ajit, we have ultrasound in the ER right now. You have already been using, so that is he's already implementing what we are talking here. But I think today we are going a little step ahead with a more advanced machine which has come. But already Dr. Ajit is using such kind of a machine in the ER. So what we do in our EPAS is that we look right upper quadrant, left upper quadrant, and look for spine line to confirm pneumothorax. Does anyone know what is spine line and what is the principle behind that? So as we said earlier, the air and the bones are going to reflect the waves. So in a normal case scenario, when we are imaging above the diaphragm, the thoracic vertebral bodies actually will not be seen, because the aerated lung will immediately reflect the sound waves as they enter, right? But if there is hemothorax, it will allow the waves to pass through the fluid, because fluid allows the waves to go down easily, and they will finally get reflected from the thoracic spine. And then that spine line which will be seen in that case. So if you see the spine line above the diaphragmatic level, that means it is a possibility of hemothorax. So by using such methodology, we can really diagnose a case of pneumothorax. In pelvics also you see retrozygal fluid space in males or pouch of Douglas female, where if you see fluid, it means pneumothorax is a good chance. We'll obviously in the subxiphoid view, we will check the cardiac for the collection of fluid around the heart, that is cardiac tamponade happening because of bleeding there. And obviously it has been shown in trials also that this study is far superior to supine chest X-ray or pelvic X-rays done for free fluid. So definitely this is a far better technology and faster technology. the second case scenario, a case which is coming with undifferentiated C4. A 68-year-old lady suddenly collapsed at home, cold clanging, BP 76 by 40 when she got to the emergency room. What will be the differential diagnosis? This can be an MI, cardiogenic shock, or a ruptured aortic aneurysm, relatively rare, but it can be a massive PE also. Now, if we are to differentiate between PE versus cardiogenic shock or any other cause of bleeding causing this rush protocol that is implemented will look at the pump tank and the pipe. I'll go into details further. But this particular patient, we saw that LV is hyperdynamic. So it is not obviously a cardiogenic cause and severely dilated but collapsing IVC. So this dilated IVC means the right heart pressure has gone up suddenly, and that is most likely because of acute massive PE, and that's why an immediate thrombolysis can be started. So see how fast the diagnosis was made and the treatment was initiated because of the rush protocol, that is rapid ultrasound in the shock case, and where we check the LV function, RV strain pattern. You look for the IVC collapsibility index. IVC, now most of our residents or the intensivists are already doing it in the intensive care. They will look for the IVC diameter. If it is less than 2.1, it is relatively small. More than 2.1, it is more, and more than 50% collapsibility obviously indicates that the person is fluid depleted. So these kind of protocols are already set. And you also look for the abdominal air curve for the aneurysm, and this rapid ultrasound can definitely help us to differentiate the shock in just 2 minutes at the bedside, and the treatment can be initiated. So that is the beauty of having this handheld ultrasound. Let's see the third case scenario. The patient has come now in a gasping state to the emergency. 55-year-old male, severe respiratory distress. The patient has history of both COPD as well as congestive heart failure. So when the patient comes with breathlessness, you don't know whether he is suffering from which of these two. On examination, the wheeze is there. So wheezing is pointing more towards COPD sometimes we feel, but we know that even in cardiac asthma you can get wheeze. So that is not really going to tell. See, very often in ER we have a tendency for such patient, ऐसा आ गया तो उसको ऑक्सीजन लगाओ, लासिक्स भी दो, डेरिफेरेंस भी दो, एफकॉल भी दो, everything we give. Because we don't know the diagnosis. So we are treating actually for respiratory as well as cardiac all together. But if we have correct diagnosis, we will give pointed treatment. So we do a 4-point anterior lateral lung ultrasound exam, and on sonography we find there are B lines. That is, and with an intact lung which is sliding. So lung sliding intact, there is no pneumothorax, and B lines indicate that there is fluid in the chest, and that is what is allowing the waves to go in, and that's why you should see those rockets like this. I have purposely not put any pictures in this presentation because I know that each of this topic is going to be discussed at length later. So you will be taught every time with good pictures to follow. But I'm just giving you a hint of everything and how it can be used. And that's how it confirms the acute pulmonary edema. We started the patient on bypass and appropriate medical management for cardiac failure was initiated, patient responded. So a quick ultrasound, looking for B lines, and we get the answer, and the treatment starts soon. So time is money and time is life. So how soon we treat, the patient gets good results and good outcome. So this is the blue protocol that is used. These are all acronyms or abbreviations that we are using. Bedside lung ultrasound in emergency. So where we see A profile, that is normal lung with sliding of the lung that is seen at A line, the seen that is generally seen with COPD, asthma, pulmonary embolism. Also, the lung will be normal. That's why in such cases coming with breathlessness, you will see A profile. But patient coming with alveolar fluid, pulmonary edema, you will see the B profile. If the patient has consolidation, pneumonia, you will get hepatization of the lung, which is the C profile. And in the A- profile, you can see that lung sliding is abolished with a distinct lung point appearing, which is a case of pneumothorax. So this is having good higher sensitivity than the standard supine chest X-ray that is done. So obviously ultrasound scores over the X-ray or standard radiology. So what is the role of POCUS that we saw some cases in the emergency setting. Now let's see how POCUS works in intensive care also. So similarly, as we discussed, when the patient has dyspnea, we can use the focus to differentiate between cardiogenic and non-cardiogenic. The fluid responsiveness can be judged by looking at the IVC. You can obviously, a case of high creatinine patient walks into you and you don't know whether the patient has got obstructive neuropathy, patient has got pre-renal azotemia, or patient has got acute renal injury, and that also can be easily see. Examining and looking for bladder is not easy, especially in a obese patient. You just have to do percussion and imagine. Again, if you have to wait for the radiologist to come and put the probe, it may take few hours. I was just narrating the story of one of my patients who got admitted out of the hospital where we could not get the radiologist, but I could request my ICU doctor to take the machine, not the handheld one, but the other one which was having a cart and it could be taken to the ward. And we just confirmed that patient is not having urinary retention, creatinine or 8.7. So my patient was taking some urine, because some urine was seen for that. So all this is possible, and the good part is that the non-radiologists have now taken the interest in this field. They are complementing the radiologist, not replacing the radiologist. So assure and ensure that your field remains intact and you will be definitely doing far superior work and more advanced scans. Obviously, the radiologist will keep doing. This will give up बच्चों का काम हो जाएगा आपके लिए, तो बच्चों को ऐसा काम करने दीजिए तो आपका काम थोड़ा और आसान हो जाएगा. DVT also can be picked up even in an emergency setting. So whether to start treatment urgently or no, you can see the vein compressibility with even handed ultrasound that can be done and the clot can be confirmed. So this all is possible in intensive care. Is it replacing the physical exam? Yes, to a large extent it can replace a physical exam. So instead of looking at RAS and crepitation, you look for B lines to diagnose pulmonary edema. Instead of looking for absent red sound, you look for lungs-like sign to diagnose pneumothorax. That is absence of lungs-like sign. Instead of looking for neck veins and JVP, this used to be a very regular exam question or to have you checked the JVP and demonstrate JVP used to be a exam question during our time, practical. Now it will be can be easily visualized using the handheld device. Look at IVC, look at IJV, and you can measure the CVP. In fact, the use of ultrasound while inserting the lines also has been amply shown for last many years. We can during my time, I still remember when we used to insert the central lines. It used to be all blind punctures, and at times the punctures used to be more than one for obviously traumatizing the patient. So subclavians also I have put many and some even IJVs, and then we used to all go in blind way and एक बार वो blood आ गया मतलब push kind of feeling that used to till that time you keep puncturing in different direction. Now with the help of ultrasound you can see the vein correctly and put the line. So these are all technological advances which I have seen in my some years of practice. So, but there are obviously going to be some pitfalls which we have to remember. So, one first thing is that just because when we start doing ultrasound and we get some finding, don't stop at that. Do a complete job. So just don't stop the scan after finding one abnormality. That is, don't prematurely close your scan. Fluid in the abdomen may not always mean blood. It can be ascites, so we have to keep that in mind. Sometimes a clotted blood in the Morrison pouch may become thick and it may not look like fluid and it may look like liver. So you have to remember that just because it is looking a little liver-like shadow is there, it may not mean that there is absence of peritoneum. The machines can misinterpret. So as we said, ultrasonography is dependent on reflection and echoes. It is like you are standing in front of a mirror and you are seeing your image, and depending on that you are imagining what the mirror is like. If the mirror is giving a very sharp image, we consider that it's a very good quality glass. So if the image is fuzzy, then you imagine that it's a different kind. If you are looking thinner in that image, then you may imagine that okay, this is possibly a convex mirror. If you are looking fatter in that mirror, then you may imagine okay, this is a concave mirror. So all these kind of things we have seen in like when I was a child, especially when you used to go to the fair, etc. There this kind of these mirrors used to be there. You will imagine what mirror is. So these reflections can be misleading. So you have to keep that in mind. So bowel gas can in fact give false impression about abdominal aortic aneurysm, or even in acute DVT when they are putting the probe in the groin. If the patient is obese and bowel gas is somewhere obstructing, you can give false interpretation. Similarly, the mirror artifacts can cause a false appearance of posterior pericardial effusion or a false appearance of supradiaphragmatic mass. So all that is to be kept in mind. The important thing is to change the angle of the probe and just confirm when this kind of artifact is possibly imagined. And what we resolve after knowing all this information that I gave you, that the benefits of the ultrasound as well as the disadvantages of the or the pitfalls in the ultrasound, what we resolve at the end of this information is that ultrasound findings are always going to anchor or it is going to enhance the clinical context. So it is not replacing clinical context, it is not replacing a doctor. Doctor has to keep his or her mind intactly thinking and don't get machine dependent. The final decision is obviously the doctor's decision or the clinician's decision, but the machines are going to help us to get a better diagnosis, and that is how the technology is going to help us. So in conclusion, focus can change the management in a significant number of critical patients. Definitely, it can speed up the management. It can definitely help us to treat the patient faster. It is a visual stethoscope because it has become now so easy to carry. The machines have become so sleek that you can just keep it in your hand or in your pocket or around your neck and just walk into your emergency room and do the assessment. Maybe Dr. Ajit will start asking what I have. मेरा सोना के मेरा सोनो के Ajit when he asks call his resident, he will not ask for anything like a stethoscope, he will ask for only sono probe, and that's how the diagnosis will be achieved. But the definite thing to remember is that it is not easy to do ultrasound, it is definitely observer dependent, and there is a learning curve. And I think that's why we all are here, because we want to make a beginning somewhere, or those who already know want to increase. So all of us may be at different levels of their learning curve, and that learning curve will go on and their accuracy will improve, and then only you will be able to give the treatment to our patients in the best possible way. So I wish all the good luck to all the attendants who are here to enjoy today's day, learn as much as possible, because this is a technology which is going to stay for long. This is a technology which is going to help us treat our patients in a faster and superior way. So make the best of today's day, learn all the skills that are going to be taught by experts like Dr. Ajit and Dr. Deepti and our radiology friend Dr. Rupali. So all of them will be teaching you the skills. More and more you learn, because I see the real young residents are here who are doing their MD medicine, PhD medicine. So they are the ones, for them a long career is there in front of them, and they can definitely use this to the best advantage. So thank you all. The ABCD approach Dr. Ajit has actually had told me to mention. So if time is there, I can show some slides which Ajit had given to me. But if it is not necessary, I